Hello, everyone. Today, so we have Dr. Uswa Ramzan from Australia and Dr. Foster and Dr. Amna from UK. And today we are going to discuss some important things about sacroiliac joint dysfunction. So before moving towards sacroiliac joint dysfunction, let's start with what is SIJ dysfunction and SIJ generalized pain. When we talk about sacroiliac joint dysfunction, that means any change in the any mechanical fault in the sacroiliac joint biomechanics, which means it could be hypermobile or it could be hypomobile. And in both cases, an individual or a person can report pain in the sacroiliac joint area, which means directly over the posterior superior iliac spine. When we talk about the sacroiliac pain, other than the dysfunction, it could be sacroiliitis, which is more like any type of inflammatory process in the sacroiliac joint area. All type of inflammatory changes, which could be more like cellular rather than mechanical fault or mechanical dysfunction. So sacroiliitis means needs medical management, whether it's conservative or whether it's surgical management. But sacroiliac dysfunction comes under the category of mechanical corrections, where physiotherapists and all other type of healthcare providers works together, including specialists as well. As we know that sacroiliac joint forms between your sacrum and your hip bone, which is ilium. So it is actually a pelvic girdle which gives us a base and stability for all type of forces coming from your upper limb, and it bears and distributes loads from your upper body to lower body. So what type of forces we are talking about is more like torsional loads, rotation and tension. If we talk about the normal mobility at the sacroiliac joint, so it's still a synovial joint having synovial fluid, but it is less mobile in general, or according to the biomechanics or the natural behavior of the joint. It has less mobility, but that doesn't mean it's a locked joint or it's a fixed joint. It has less freedom of movement. So, before moving towards diagnostic categories or the tools which we will consider when we talk about the diagnosis, we should know about what can cause sacroiliac joint pain. So the causes of sacroiliac joint pain is acute. Acute means direct injuries to the structure of the joint, which could be acute fractures to the sacrum or the iliac pathologies, more like mechanical dysfunction. And the repetitive traumas. So, repetitive trauma could be just the normal day to day activities where you are overly stressing your sacroiliac joint.
Even falling as well
Yeah,
or
exactly.
twisting.
Yes, and if we generally talk about what could be the just the day-to-day activities which can give repetitive stress to the same area, just cleaning, bending down, vacuuming, mopping, all type of
Household.
even yes weight-bearing activities, prolonged even standing, stair climbing, all and so all these type of factors are somehow within the house or unavoidable factor as well, being a normal candidate. The third possible reason which gives pain to the sacroiliac joint area is even pregnancy associated SIJ pain. We all know that we have more laxity in the soft tissues and the ligaments. And if we talk about the pregnancy, so during pregnancy, just because of the fetal development with the passage of time, so your SIJ is more wider and more opened. That means more laxity in the ligaments surrounding or providing stability to the SIJ. So this could be the another cause for SIJ pain. The fourth cause is it could be idiopathic as well. Or another reason could be any type of abnormality, like structural abnormality, if we talk about the ilium or the sacrum. Clinical presentation for a candidate which could come under the category of sacroiliac joint dysfunction. So whenever we talk about the assessment, we have formal and informal observation. When patient comes directly and walks to your um, our clinician's room, so we do have an informal assessment where we observe patient's gait in the walking style or just the body compensation because of the pain behavior and pain pattern. Other than this informal observation, when we talk about the symptoms which your patient can present with sacroiliac joint dysfunction is um, pain over palpation of posterior superior iliac spine, typical pain presentation which could be radiating down into your posterior buttock area and down to your posterior thigh, but it should not cross your knee. Pain in sit to stand. So after a long period of sitting, if somebody has to just randomly stand up, they can categorize this type of pain. Pain during stair climbing, pain during all type of weight bearing activities, prolonged walking, stair climbing, and as we have said previously, just normal functional activities which needs like repetitive bending. So somebody can think about these factors or this type of presentation or this type of symptom could be labelized for a person who is coming to you for lower back pain. That's why we have a special physical test and standards of marker where we can categorize a person for sacroiliac joint dysfunction, or pain is coming from your lower back, or there is some sort of dysfunction within your hip region, because we always have to assess the neighbors instead of sticking always to the area which is sore. So coming to the physical assessment, it's always important never ignore or neglect lower back pain and the hip area. This is very very important before going towards differential diagnosis or before going towards the physical test and assessment. So literature is saying that there is a physical like maneuvers which where you have to apply a special test and reproduce the same type of pain with which your patient has presented to you. And out of the 5 markers, if 3 of them are positive, 3 of the special tests are positive, you can labelize this person that this patient has pain coming from your sacroiliac joint. So special tests, in special tests, the first one is the Faber test, which is flexion, abduction, external rotation test, where your patient will be in supine lying position. I think I should just share my screen. I have some screenshots to just show you, and then we can discuss about the special tests for sacroiliac joint pain. Sorry.
You you do know na that Faber is a mnemonic for flexion, abduction, and external rotation.
Yes,
Faber F.
yes. I have added this.
Yeah, flexion is flexion, F flexion, AB is abduction, and then
Yes,
ER is
external
external.
rotation. Yes. Just give me a second. I'm just uh, some sacroiliac joint. Um, can you see something on my screen or no?
Yes.
Okay, so can you see that I have opened an image showing Faber test for sacroiliac joint?
Yes.
Okay, so this is the Faber test, FABER, which is flexion, abduction, external rotation test, and its second name is Patrick test as well. You can see the photo attached below, where your patient will be in supine lying position, lower extremity ipsilateral to the patient's painful SIJ is correctly positioned by lying their lateral ankle on the contralateral. So it's more like just crossing your leg, your affected side, and therapist is standing on your affected side as well. So with one hand, therapist has to stabilize your contralateral hip while adding downward vertical pressure through the area of hand placement you can see in the photo. While applying downward pressure and stabilizing the pelvis, if patient is complaining reproduction of the same type of symptoms, you can it can suggest us. We can't say that it's typically Sij, but we can say that it gives us suggestion of this pain is coming from your sacroiliac joint. This is the first test. um, the second test is high thrust test, which is posterior shear test, for which the patient is lying in a supine position. The hip and knee ipsilateral to the painful Sij are flexed, and femur is positioned perpendicular to the table, as you can see in the image. A linear downward force through the femur towards the table is applied as depicted by the arrow by physiotherapist. If on application of this force, patient is complaining for reproduction of the symptoms, we can suggest that this can come from your sacroiliac joint. Sacroiliac joint. So the third special test for Sij is Foster. How you pronounce it?
I think Geinsline.
Yeah,
This is
some people says
Yeah,
Geinsline. So
guys.
okay.
Geinsline.
Yeah.
Yes. So in this, while stabilizing patient's flexed knee, as you can see, therapist is stabilizing patient's flexed knee with the right hand. A counter force depicted by the arrow is applied just vertically through the hanging leg towards floor. So you can see that the physiotherapist is standing on the ipsilateral side, which is the testing side, and this side is almost off the couch, and physiotherapist has to apply a vertical downward force. If on application of force, patient is complaining for reproduction or aggravated symptoms, it can suggest us that pain is coming from your sacroiliac joint.
So
So
the
this,
pain will be in the leg that's hanging down. Is that the
yes,
tested?
yes, and in the Sij area, which is more like your pain around your posterior superior iliac spine. Any questions?
Can you tell us the type of the pain in each
Ah,
test?
type of
Yeah,
the
it must be
pain.
excruciating.
Yes,
Excruciating,
it
yeah.
could be. It will be. So Sij pain. I'm just coming back to the camera. Just give me a second. Just a second. Yes. So this is an important question. What type of pain? So Sij pain is not sharp pain or burning pain. Patient can say that sometime it could be sharp with specific activities like bending down or um mopping, vacuuming, or cleaning, but most of the time it's more like dull pain because
And
we
I
will be
think it's not
discussing.
radiating to the leg.
Yeah, exactly. Yes,
Sometimes it is
and
that.
it
Because if
radiates
it's
down to
radiating
the
to leg,
buttock
we can,
area.
yeah, we can differentiate between sciatica.
Yes, exactly. And another thing between Sij pain, if it is radiating down to your posterior thigh, your sciatic pain is definitely a typical like pain pattern which could be engaging your lower leg as well, and numbness and pins and needles. So typical presentation of nerve compression as compared to your Sij, which never crosses below your knee. So
But
most
it
of
is
the,
also a radiating pain.
yes, it,
Is
so it we can say it's a referred pain pattern coming from the Sij.
It's a referred pain pattern because neuropathic pain is more like burning and sharp and shooting pain, and
Yes,
it's more like posterior. Sciatic pain will be sharp, more lateral posterior pain, and the type of pain would be more burning. But that's why, as we discussed before, that's where palpation comes. When you palpate, your SI joint will be specifically sore instead of
yes,
central lumbar, agar back say if it's back, then central lumbar tends to be more, central lumbar spine is more tender. If it's SIJ, then on your PSIS, on your sacral dimples, you will feel it's more tender
Yeah,
over there.
exactly. And
Okay.
on
Yes.
spring test, like patient will be all okay for your lumbar spine spring test on pressure, but he could be sore or she could be sore for your posterior superior iliac spine area, which can give you a good clue of like lumbar spine is all good and this patient is typically presenting with SIJ pain.
Yeah. Carry on.
So yes, so just going
So
back
spring
onto,
test is compression test?
so spring is,
Just mobilize on your
yeah,
back.
so
Literally pulse each
I can
vertebra.
I can show you. So spring is more like just an assessment test and the treatment where, so it's more like a mulligan technique. So PC
Okay.
form, yes, PC form on PC form, and this will be engaging your spinous process. So I'm engaging L5, L4, L3, L2. So keep asking patient, I'm applying a certain pressure on your lumbar spine, targeting
Mm-hmm.
individual vertebra. If you are experiencing any type of pain, or if it is giving you the same type of pain, or it's a different pain, you can tell me. So patient will be all good on your lumbar spine, but when you are just leaving the lumbar spine and going onto the PSIS and applying again a downward pressure, patient will be almost jumping because of the pain.
Okay.
Yes.
Yeah, we
It
say
is like
jump spike
common.
and then muscle guarding, yeah.
Yes, and that's the another thing why this pain is not sharp, because it does involves your like underactivation of opposite contralateral latissimus dorsi and ipsilateral glute muscles, and particularly gluteus maximus.
Say that again, please.
So in
Contralateral.
SIJ dysfunction, when we talk about the mechanical fault, it
Mm-hmm.
means underactivation of contralateral latissimus dorsi
Mm-hmm.
and ipsilateral gluteal muscles, particularly gluteus maximus.
So we can say cross.
So
Exactly.
Yeah,
gluteus,
रख सकते हैं.
gluteus maximus is also uh, under underactive.
Yes, underactive gluteus maximus, underactive.
Okay.
It's more like reciprocal relationship between both. So Amna is right, and even when you have patient and you have long ongoing follow up with them, they will
Mhm.
be giving you a typical presentation of even lower cross syndrome. So that's more like a secondary things involvement, but that's not the cause.
Lower cross is always like whenever you have low back related pain, low back, you will always tend to go, your abdominals will become inhibited and your glutes will become inhibited and your flexors and your erector spinae will be
Yes,
overworking. Lower cross always comes with low back pain.
exactly.
Yeah.
So these three tests, Faber test, we talked about thigh thrust test, and we talked about Gainsley's or the test. Okay, and the rest of the two tests, I'm just going back to share just my screen. Can you see my screen?
I think it's compression and distraction test, isn't it?
Yes. Can you see my screen?
Not yet.
No.
See
Okay.
video pause. Video
Okay.
pause.
Okay. Just a second. Yes. Is it showing you something now? Can you see?
Yes.
Okay. Okay.
Yes.
So this is the test 3. The fourth special test is again the modified, the same almost modified test number 3. And this test is only like more like specific for people. Sometimes patient can't lie on the back because of more irritability, not the severity, but more like irritability because of the pain. So this position is really good, and it still involves the same maneuver which we were doing in test 3. Okay, so just to
It
a
is
good
same like a
comparison.
Ober's test.
So in Auber's test, this leg could be like your leg which is contacting your treatment couch could be straight as well, because we are just focusing on the upper leg. But in this, you can just like do comparison between this one and the previous one. They are almost same, but just the position is the
Mm.
side lying, because I do treat
Okay.
a lot of people and sometimes it's really hard for them to lie on their back. So you can test them on the side lying as well. Painful Sij is away from the table. So painful Sij is facing towards ceiling, while the hip knee flexed and the hip flexed hip is your non-painful side, which is um, facing your treatment couch. Examiner stands behind the patient who is positioned at the edge of the bed. Stabilize the pelvis using one hand. As you can see in the diagram, physiotherapist is stabilizing the pelvis with the left hand, and apply firm anterior pressure and then extend the patient's lower extremity at the hip ipsilateral to the painful Sij. This is more like a modified test which still gives us aggravated symptom into the area of sacroiliac joint. Any questions, any confusions, you can stop me at any time so that we can discuss.
All good.
Okay. So this is the next test, which is compression test. Very important test. Compression test you can do in supine lying position and in side lying position as well. Patient is positioned in a lateral decubitus position, which is more like you can see in the diagram. The treatment hip treatment side is facing towards ceiling. While standing at the level of the pelvis, examiner applies firm downward force through the ilium as seen by the arrow. So literature is saying that you can apply compression test while patient is lying on back, just like this one. So this is the distraction test, but you can apply compression test while patient is lying on their back, but your force direction will be more like towards like inner side towards pelvis. Whether here it's more like distraction force. Are you okay with what I am saying, or should I repeat?
Yeah, it's
Yes, yes.
good.
Yeah,
Okay.
you're okay.
So distraction test. These are the possible 6 tests, and we have another test as well, which is Geomain test, in which your patient will be prone lying with positive side knee flexed to 90 degrees. Sorry, I don't have photo of that. That's why I'm just discussing. So your patient will
Okay,
be
yeah.
prone lying and the tested side will be flexed at 90 degrees knee flexion.
What is it called? What is it called?
Geomain, Yeoman, Geomain test. So physiotherapists do hip extension.
Okay, manual hip extension.
Yes, on the side where knee was already in 90-degree flexion. Do you understand?
Yeah.
So positive anterior Sij ligament. So it's more like if applying force in the direction of hip extension and patient is complaining reproduction of same type of pain, it gives us or it suggests us pain is coming from anterior sacroiliac ligament. If with hip extension where knee is 90-degree flexed, patient is just complaining about some paresthesias in the front groin area, which means there is some sort of compression or stress on your femoral nerve, or there could be
Hmm.
tightness in the front thigh muscles. I'm coming back on call. Sorry, I should stop recording. So, the last test is Geomain test, where your patient is in prone lying position with the tested side knee flexed to 90 degrees, and you just have to do hip extension. With this movement, if patient is complaining pain in the posterior superior leg spine area, that means this is coming from the Sij and targeting Sij ligament. If patient is saying no pain in SIJ area but just some different feeling or maybe funny feeling on the anterior groin area, that means you are actually just adding some stress on the femoral nerve, or could be just tightness in the hip flexors, which we already have discussed that lower cross syndrome always involves your tightness in the hip flexors.
So the question is that should we land directly towards these tests, or should we rule out the muscle before because it can be spasmatic muscle and
Okay,
it can be no joint involvement. So should we in assessment should we very first step should we go towards the test or should we go towards the muscle assessment
very
first?
important question. When we are starting objective assessment, we always start with palpation. So when we are
Okay.
palpating, that gives you an understanding of, okay, I feel like erector spinae are tight. I feel like glutes are hypoactive and hip flexors are tight or things. So all the possible things which are already in your mind that they could be tight, they could be underactive, I can confirm while palpating. And then I can reconfirm them while applying a special test. And while you are applying special test for SIJ, patient will be giving you typical pain in the SIJ area. It will not be like, okay, I feel like my muscles are tight. No, I am experiencing the same type of pain, and it's always just on one point. It always
Hmm.
starts with like pain more localized in the posterior superior iliac spine, but sometimes patient says, yes, sometimes it can radiate down into my buttock area and back thigh, but most of the time it's just localized in this area. So patient always just give me a second. So when you have patient with the um, SIG pain, patient will come to your clinic with this presentation. My this area is only sore and that's it. That gives you a
Hmm.
typical sign of I have to rule SIJ along with the lower back and the hip.
So what
Uh,
is the occupation that causing the pain? Like it is the chronic presentation. So what causing the pain trigger it?
Good
What
question.
is the
repetitive
posture? What is
motion
the occupation?
ergonomics,
Yes. So
office
occupation.
jobs,
When we talk
lack of
about,
use.
I recently had a patient with sacroiliac joint pain, and so she by profession she is administrator, which needs prolonged sitting jobs. So all type of uh,
Office job.
when even I was doing my master's, it was my research title as well, sacroiliac joint dysfunction. So it always needs occupation which demands more sitting, prolonged sitting. All
Okay.
type of desk-based jobs, computer-based jobs, administrative jobs. It's more common in
Hmm.
them.
Okay.
Yes,
And even back pain is also
As
more
well.
common in prolonged.
Sometimes I think it is because of
yes.
repetitive motion,
Even
and if you don't
exactly. So chronic back pain.
have so many breaks in between.
Yeah, because like when you're standing, technically, the joint reaction forces are not directly on your spine. They're coming through your feet and then all the way up. So by that, the time they reach your spine, I think they're already half used up in your legs and stuff. But when you're sitting, you're having that direct contact with that hard surface, na. So I think kind of gives more compressive forces on your back when you're sitting. So that's why prolonged any kind of prolonged sitting is
Yes,
it tends to give more
and
low
exactly.
back pain
Yes,
issues.
and
And
This
what
other
is
than
the
that's why occupation is very important. When we ask about, okay, can you just tell me about your occupation, that gives you another clue. And sometime like housewife, no occupation but still has to do a lot of bending tasks.
bending jobs, yes, and manual
Exactly.
lifting it
Yes.
loads your manual
So
lifting.
it depends on what is causing. Occupation is important, but it depends on what is causing. As we have discussed before, it could be acute or it could be because of the repetitive, like pregnancy, another typical thing. If you are seeing a pregnant lady, you could be aware of, yes,
Even
because of the laxity.
area,
and what is the gait pattern? Like what is the presentation of the gait pattern actually it is?
this was my question. I thought I'll keep it for the end, the gait pattern. But if you want to tell it now,
Okay.
Yeah, she showed. Binish
Sorry?
told us
Okay.
when Binish
so
told us
so
when she stood up and she. Yeah.
if you are talking about the very sound types of gait, as like all the neurological conditions have special types of gaits. It's
Yeah.
not something like that, but it could be a limping gait pattern where
Intelligent,
Yeah.
intelligent gait, where your patient will be having short stance on the side which is sore.
affected, yeah. And plus, you might see that one PSIS might be a little bit higher than the other.
Exactly.
So your,
Yeah, this is the
That
point. Yeah.
that's
your
very important. So that's why you
That is
do
the
drop
first
test.
presentation. Yes.
Yes,
yeah.
drop
Yeah.
test.
Mm-hmm.
So
Hmm.
drop test involves physiotherapist has to stand with the patient, and your one hand should be on the posterior superior leg spine. So I don't have any
Mm.
model, but I can actually show you.
I
So
think
let's
if
assume
someone patient come to me, I will do this test first.
exactly, and this is really like the gold standard. Some articles are saying this is the gold standard. Some of the articles are saying that out of the 5 maneuvers or 6 maneuvers we discussed, if 3 of them are positive, but important is if compression test, there was like thigh thrust. So out of the 5, 3 maneuvers should be positive to labelize any type of patient with sacroiliac joint dysfunction. But condition is one should be positive whether compression test or thigh thrust test.
So they
Okay.
are more specific
Yes,
rule
so
out.
that gives us an information of their validity and reliability.
Hmm.
They are more sensitive tests and very specific for SIG. So
SIG.
drop a test is more like patient will be standing and one thumb should be on PSIS and one will be on the
Mm.
sacrum. So you have to
Okay.
ask patient that just do this movement while you are palpating how ideally the sacrum is moving. Sometime it could
So
be more. So if it is
can,
if it is more moving, like you feel like actually it's going more up.
can you please tell the hand position, labeling the affected side and the non-affected side, where and where, like in that way? I'm saying, for
Okay.
example, if affected side is the right side, then tell the hand
If
placement, please.
affected side is the right side,
Mm-hmm.
so your this right thumb, one thumb could be on the testing side posterior superior iliac spine, whereas the other thumb will be on the sacrum just to feel the stability or just to stabilize.
Hmm.
And then you will ask patient to just do hip flexion.
So non-symptomatic side, you're gonna put it on the SIJ,
Sacrum.
sacrum. Sorry, yeah, sacrum, and PSI is on the affected side.
Yes.
Hmm. And
And
how the feel would, how would be the feel? What would be the feel?
Rotation of the sacrum. Is
yes,
it?
so it's I'm just trying to exactly feel how when your patient is doing hip flexion, the thumb which is on the posterior superior leg spine, if this thumb is going up,
Mm-hmm.
as ideally your sacrum thumb should be going down. I
Down.
need
Yeah,
to,
I would think.
yes,
Yeah, you have.
exactly. So but this
Don't
is
worry
just
about
a
it. Just
very
right.
very few degree movement.
Yeah, yeah,
But it could be just normal in some of the people who are already hypermobile genetically,
yeah.
or it could be just locked. So it's always
Yes.
better to do comparison for the other side.
This was my next
Question.
point. Is always look for hypermobility, because they might be having that pain because of hypermobility. So do
Exactly.
your bite and score
Yes.
for hypermobility
And
test,
and
because
and these testing, whether it's hypermobile or hypomobile, will give us an
yeah,
understanding of when we are talking about the treatment plan.
yes, yes, yes,
Uswa, are you okay with what
Yeah.
we are saying? So always
Yes. Yes.
test for the other side to do. So drop test is really good, and thank you for adding great yes information in this. This is really important.
Yeah. There is one thing that if we see the gait pattern, we can also see the if the patient presenting with the chronic pain, we can also see the leg length discrepancy.
Very important. Exactly.
Yeah.
Yes. And s- s- even length discrepancy, or if you talk about a thorough detailed assessment, even just check for their normal curves of the foot, whether they are pes cavus or pes planus.
Mm.
If nothing is helping you or supporting your diagnosis of, I'm confident that this is sij, but what is contributing, what is adding
Yeah.
mechanical changes, so then we can comment about, yes, leg length discrepancy, or maybe pes planus, pes cavus, or something like that, maybe just the altered mechanics of rest of the other joints.
To be
Mm.
honest, physiotherapy, there is always another contributing factor that's affecting that joint, and once you start treating that factor, your symptoms will automatically resolve. I found it in a lot of cases when you do it.
Yeah.
As soon
100%.
as you start controlling the contributing factors, it automatically starts to settle down. And don't bother about the muscle spasm. Muscle spasm is just normal body reaction. It's not a diagnosis. Trigger points are never a diagnosis. Spasms, tightness is never a diagnosis. There's always something else going on that
Yeah,
causes muscles to react and sort of set in a pattern that some of them goes underreactive, some of them go overreactive. So your overreactive muscles will then become like, initially all of them will be tight because it's initial stage, but then they will start setting into a pattern. Some
yeah,
of them doesn't mean that it doesn't mean that if your muscle is tight, it's always overworking. It could be weak, but it's tight.
Mm. Right.
So your muscle tightness is never a diagnosis. It's always a
exactly.
symptom.
And
And
sometimes patient can say that, yes, I was having some sort of pain before, but yesterday I just did something, like it was not really heavy something, but I tried to just lift something, and now this patient is not only sore for the sij, but having very bad muscle spasm in the paraspinals. So don't, again, we should not be getting confused between, it could be it is coming from the back or it's just the muscles. But once this patient is coming on follow up, all the symptoms will be get settling down, and we will be getting more specific into the area from where the pain is coming.
Yeah.
Your muscle spasm can just settle down in 2 to 3 sessions, and that's the maximum time.
Okay.
These are the special tests which we being physiotherapists, and believe me, there was an article, I need to just check that again. Physiotherapist is the first line of treatment provider who has to assess clinically sacroiliac joint dysfunction, and based on these maneuvers you
Mm.
can confidently document it that this is sij dysfunction. You don't need
yes,
any type of investigation, but to confirm it for the future, like not every sij could be can be 100% treated with all type of physiotherapy or rehabilitation. Maybe it just needs some type of other conservative approach, like medical management, where specialist has to inject cortisone injection, or like ct guided injections. And not all type of cases are managed 100% with this approach. Sometimes they need some advanced management, then you need like investigation. MRI is a gold standard, where you can see, and even start with the x-rays to see even sij arthritis.
Mm.
Patient can give you again this type of picture. So think about something, if x-ray is coming all clear, then having a conversation or talk with the specialist, then they can send for MRI.
Mm.
An MRI can give you picture of some, if something is inflammatory, like more like bone marrow edema, which is sacroiliitis, not the sacroiliac joint dysfunction.
yeah.
And how
Right.
are the ligaments surrounding SIJ? It can come up on MRI as well.
Okay. The arthritis presentation would be a ipsilateral or bilateral?
Arthritis
Yeah.
Could be any. Could be.
could be
Could
any,
be.
because one side bad arthritis will be overcompensating the other side, because I'm sore for one side, my gait pattern will be totally different because I have to save every time myself just to get rid of the pain, and I can overuse my other side. So other side will be more like, just because of overuse, now I have developed arthritis in the other side as well. Or it could be
Most
together. If somebody is like
bilateral,
age, yes,
it could be unilateral, it could be bilateral. Bilateral involvements are usually in inflammatory patterns like your rheumatoid arthritis, or anything that is coming centrally, like from a central spinal cord compression. They will give you bilateral involvements. But anything locally, like in osteoarthritis, it is just like your knees. Yeah, like you can have more
yeah,
osteoarthritis compared to the other. So osteoarthritis mechanical symptoms can be symmetric, can be asymmetric, but they are rarely symmetric. They are mostly unilaterals, and there is no pattern. But your inflammatory things are symmetric. Your central
100%.
nerve related as like upper neuron lesions and stuff like that. Like more central lesions
Yes,
tend to be symmetric. I'm just generally giving like an idea about.
yeah. No,
So
you are right.
Amna has dropped the call. So how can we add Amna?
Maybe if she's with patient,
Okay, no worries.
we
You
can
just
con-
you can see it on YouTube. Just
yeah,
continue.
because it seems like she's busy, and if she's easy, she can join. There is always option.
Yeah, she can always come back.
Okay. So, coming towards differential diagnosis, we
Mm.
already have talked about never ignore lower back pains or the nerve compressions are at lower back level, especially L4, L5, L5, S1, and the hip girdle as well. This is important every time, and this is just the first line of assessment when you are assessing your SIJ, your
Yeah, because
patient's
your
SIJ. Yeah,
Fab- Faber is also positive in your hip issues. Always,
always. And I
always
think
do.
Faber is a good start, which gives you
Yeah,
an indication of
Faber is
something
good
is going
general
wrong
idea
with the
of
hip.
our local regional. It's a regional, like, okay, something is going on in this area. If Faber
Exactly.
is positive, yeah.
Yes.
And research says if there is a limping sign, if there is more limping, then your hip is rather more involved. It is 6 times more likely to be involved than your lower back if there's a limping on a side, according to research. Yeah.
Say it again. Say it again.
So if there is limping in the gait, okay, and if the pain is with prolonged sitting, prolonged weight bearing on that side,
Yes.
and that is going to your groin, these
Hmm.
are specific features of your hip pain. So when you're ruling out your lumbar pain compared to your hip pain, so if there is limping, it's 6 times more likely to be hip related pain rather than your low back pain.
Okay. So, other than this, some important things. Let me to just share my screen again. Just a second. So, coming towards the differential diagnosis, this is an article I will be sending in group. This article: localization of pain to the spine or radiating pain into the lower extremities with positive straight leg raise. It gives us a typical presentation of spinal nerve pathology. You are agree on that, right?
Yes, yeah, yeah.
So the second important thing which we always have to take in consideration when doing differential diagnosis for SIJ: concomitant anterior and posterior hip pains with Faber test producing pain localized in the groin area may point towards femoroacetabular pathologies.
FAIs, yeah.
Yes, and we are not saying that this is the only thing which will 100% diagnose femoroacetabular pathologies, but this is giving us a clue.
Yeah.
The third thing is tenderness to palpation over the body of piriformis with positive FADR, which is flexion of the hip, adduction, internal rotation. It may suggest piriformis syndrome. And there is a long debate on piriformis syndrome. We can spare another like CPD properly to talk on the
Yeah,
piriformis syndrome.
I find them the most confusing. Your deep gluteal pains are
E-
still very less researched area, and there's a
exactly.
lot in the yeah. I always find it very confusing, but yeah,
Yes.
it's a debate to be discussed at some other time.
Yes, no, surely, because this is really important as well. Sometime like we are not only stressing on we are putting a lot of attention on joint or intra-articular things or structural things, but sometimes
Yeah,
functional things, they are always underrated, and they can give you a typical presentation. And if we just focus on them, your
yeah,
patient can just have relief within short period of time.
true,
Yes. The fourth important thing when we talk about the differential diagnosis is perineal pain, which gets worse with palpation over the ischial spine. It may point towards pudendal neuropathy, which is again, we are not summing it up in a sentence, but we are just quoting it enough to differentiate it with the SIJ. Otherwise, every possible case on every point needs a proper hour or 2 hour discussion.
true, true.
Yes, and the
Very
fifth point
important
is
point. This is
yes,
a very important point because yeah, the perineal pain. So does it
yes,
means when we will be palpating the ischial area, I- is it going to be like a radiating nerve kind of pain? You know, when you have
yes,
your nerve.
yes, and
Okay.
which will be surely disturbed
Mm.
different from the SIG pain, which could be
Okay.
more sharp pain.
Yeah. Yeah.
The next point is patients with reproducible pain along with the proximal hamstring muscle or tendon through various activities, like you can perform active and passive range of motion. It can give us a clue of hamstring strain, rupture, or tendinopathy, like proximal hamstring tendinopathy. Very important, and again underrated clinical condition.
Hmm.
And your patient again just points out the area like proximal hamstring area, that I am just sore in this area, otherwise my buttock is okay, my SI is okay, no pain in the back, nothing
Can
but
you show that? Can you show that point again? Sorry, I haven't read it from the start. Please, can
okay.
you get
Yes.
patient with.
Yes, patients with reproducible pain along with the proximal hamstring muscle or tendon,
Mhm.
even if
Yeah.
you're palpating the proximal hamstring.
Yeah, on the ischial tuberosity, isn't it? Where it's
Exactly.
attached.
Yes.
Yeah.
And you can just test it with active or passive range of motion as well. It is giving us some suggestion of it could be hamstring strain, rupture, or most of the time, especially if pain is more than like 3 months or longer time, and if patient has more like again the sitting habits, and believe me, there was a patient. I'm just coming back to the video so that we I can see you. The, stop sharing. Sorry. I had a patient a couple of months before for proximal hamstring tendinopathy. So his complaint was only one. He was getting better with physiotherapy. He was really appreciating effectiveness of exercise. But he was like, Benish, when I'm driving my car, I'm always sore for 30-minute drive. I don't know if maybe something is wrong with my car seat, but when I just take my wife's car for the same
Hmm.
period of time of driving, I'm all good.
Right.
And
Must
and
be
with
a lot.
yes, and I asked him that one day you have to come with your car so that I can see just the ergonomics of how your
Yeah.
car seat is designed, or whether is it meeting your body need when you are sitting properly, you are overly engaging your ischial tuberosities, or you are putting stress on the sacrum when you are sitting. And another day come with your wife's car, and I gave him exercises that before going into the car, because you need to travel a lot, especially if you have to just go out of station for 2 hours 3 hours, and you are the only person who has to drive for long trips. Do these exercises in between your trips, and don't think that you are patient and you are just doing for the sake of treatment. Just take it as a fitness part and enjoy your long trips. And then he was all good.
Very nice.
Yeah, and
Brilliant.
sometimes very little things makes a difference. Ergonomics. And sometimes they could be, no, I have, I have orthopedic like medical mattress, and I have this seat and backrest and everything. But try to figure out, try to just ask them to tell you more about what type of activities they have. Even like lazy boy sitting, which is which is
Again,
which is always very ideal for western population. But when
yeah.
I ask patient, if you I'm not saying that you have lazy boy chair, but if you are using lazy boy chair, I should say avoid that. How you can say that I have three lazy boy chair, and what I will be going with them going to do with them?
Hmm.
So just a little postural education just makes a big difference.
Again, the contributing factor is whether it's in your
Exactly.
body or body.
Yeah.
So the point is, what was the car fault? What was the chair fault?
what was the chair
Ergonomics
for?
was?
Yes, exactly.
Yeah,
Um, he always has to sunk more deep into his car seat as compared to his wife's car seat, which was quite ideal and has backrest and more like cushioned and protected. So when you are ideally sitting on a chair, your body should be properly fitted with that. Ideally,
Yeah.
and that was only one reason, because he had to travel a lot and he had to do long drives driving. So otherwise he was all good. His concern was only one: I don't know what is wrong with me, but whenever I drive my car I am sore. And then he was getting better. Definitely he took longer time, because your tendon dysfunctions takes more than months and months, like 6 months. And
Yeah.
that is completely normal, but we just have to explain to patient that, see, we are doing to correct this, but it will take longer time.
And I always say that tendinopathies are easy to diagnose, but they are very hard to treat.
Very hard.
Right? And there is still very inconsistent evidence. Like there is good evidence for your Achilles tendinopathy, but if you compare to your proximal hamstring, it's really hard to treat a hamstring tendinopathy compared to an Achilles. I mean, it gets harder when you go to like sports level. Obviously, it's the hardest level. But even tendinopathies, even though the physiological sciences are the same, doesn't mean that the rehab therapy, even the rehab therapy principles are the same as well, but even region to region, tendon to tendon can take long time. Like some
Yeah.
tendinopathies can be really easy to manage, some tendinopathies are really hard to manage. You can't treat tendon. I mean, the research is still. I was just literally just. I literally have the tendinopathy rehab article. I was just reading that, so it's a very fresh uh, knowledge. So you always have like we will discuss about tendinopathies. There is a rule of thumb of rehab for tendinopathies, but it doesn't always work with every tendinopathy. So the point is basically they're very hard to treat. Tendon are not easy to treat.
Tendons are not easy. Yes. I think while treating tendons you are already tender as well.
You are tender, and it's a very tension giving thing. Well, it's not easy, especially when you have to rehab them for return to sports. I find
Mm,
it the
exactly.
most hardest because it is a very high level, high impact work that you have to do. At that time, most of the people just lose their interest in physio. So loss to follow-ups are there as well. Like there are lots of factors.
Yes,
So and hams, I think hams proximal hams tendinopathy is one of the hardest so far that I found in my experience so far.
exactly. So
Mostly
so
because it's very loaded as well. Like even when you're walking, even though if your hams is all gone, it's more used. Like you're walking on it, you're weight bearing on it. So you're taking the load meanwhile you're rehabbing it. It's working as well. So that's
yes,
why it's. However, your shoulder tendinopathies are really good treated because they're not weight bearing joints. You're not doing much work on them all the time. However, your weight bearing their tendinopathies are hard. But this is personal experience. This is my personal experience.
no,
But I
you
have
are right.
found.
Yes.
Yeah.
So just going back to share my
Go
screen.
back. We are
Yep.
digressing.
So yes, so we were on proximal hamstring tendinopathy. Can you see my screen?
Yes.
Okay. The number 6 point, while talking about the differential diagnosis, axial low back pain that is worse with lumbar extension and positive for lumbar facet loading may be indicative of lumbar facet arthropathy. So facet dysfunction, which is almost definitely a standard marker to diagnose it, painful extension every time.
And if you combine extension plus rotation to one side, oh my god.
Yes.
Or
So the next point is pain localized over the inferior sacrum and coccygeal region may represent sacrocoxalgia or coccydynia. And coccydynia is totally different from SIJ presentation. Like it will be more like touching the sacrum is sore. My sitting is sore. I can't sit because my sacrum is sore.
It is more localized.
Exactly, more localized.
coccydynia is literally just that tip of your bone, the
Yes,
tail
and
bone,
and
very, very.
tender, very tender on touch.
It's very common in pregnant ladies as well, coccydynia.
Oh yes,
They
exactly.
tend,
So all these type of things I actually wanted to add in differential diagnosis because they actually give us an understanding of what I should rule more or what I should think about more about, when I'm diagnosing SIJ. Yes, Foster, you want to add something?
I have one question. Sacroiliac. I don't know much about that. If you have a little bit of knowledge
Sacroiliac.
about, yeah, it was with coccydynia, the word.
Oh yes, sacrocoxalgia or coccydynia is same.
Oh, is it? I didn't know that.
Yes, yes.
Okay, so it's the same name of two different things.
Sacrocoxalgia more like sacrum or coccyx,
Mm-hmm.
whereas coccydynia is typically coccyx, but most of the time it's the coccyx pain.
Hmm.
Yes,
Okay.
yes. So moving towards the treatment, I'm just saying if I'm missing anything. Moving towards the treatment, now we have an understanding of causes, which not only involves the occupation but more like the activities or more like mechanism of injury, how this has started. This is very important to ask. Mechanism of injury gives us an understanding of occupation, aggravated factors, repetitive trauma, or something like that, or it's chronic, or it's acute, or it just has started. And I was reading another article which is saying if pain of SIJ is less than 6 weeks time, you do not need any type of radiologic investigations. But if it lasts longer than 6 weeks, you definitely have to go for that because it's a matter of time now, and one thing could have engaged the other structure. So it's better to have investigation side by side while you are assessing them and treating them. Moving towards the treatment. So if it is hypermobile, definitely stabilization. We will not be going towards the mobilization. If it is already hypermobile, we don't need mobility more. It's already hypermobile. So we will be going towards all the type of stabilization, like especially pregnancy associated SIJ pain should be corrected or should be treated with straight away your sacral belts. That's very, very important to offload that area. Or stabilization exercises involves, literature is saying, um, like because we talked about underactivation of contralateral latissimus dorsi and ipsilateral gluteus maximus. So building up strength in the glute muscles is really important because it is a strong element providing stability to your SIJ. First, Uswa or Foster want to say something or okay,
No, no.
okay.
Okay.
All
And
good.
another thing is core activation, very important. Building up enough strength in your core muscles and even transversely aligned your muscles. Pelvic floor strengthening, very very important. Providing stability for SIJ pain, like SIJ, providing stability.
Like your normal Kegels and
Yes, start always with the Kegels.
what about what about side planks? Do they work on a
Side planks.
engaging core and stability of pelvis?
Yes, but you have to make sure if you are treating a pregnant lady in which trimester she is, or if we are generally talking about patient with SIJ, planks are good.
Just generally, yeah. I wouldn't be given too much to a pregnant lady because I don't want to increase her intra-abdominal pressure.
Yes,
If that, it will be using her core and might be increased. She might be like overcompensating into wrong mechanics due to abnormal, not abnormal, but other than normal weight
altered.
distribution
Yeah,
of the body.
exactly.
Yeah.
Yes. So now
You
side
know,
planks are really good, and I do advise people for side planks as well. Maybe not in a first week or second week. It depends on
yeah,
how irritable they are.
yeah,
Just taking confidence of the body, and
yeah.
then you can progress.
Yeah, always gentle too because planks are quite hard. Let's be serious, like they are hard.
Yes, and always like pain management is really important initially when we talk about the treatment. So pain management side by side, patient can have a good answers plain from their designated doctor or their specialist while you are providing them physiotherapy management.
This was my question. Can patient have the like over the counter paracetamol ibuprofen on
Yes,
their own for 2 weeks and meanwhile you're rehabbing? Yeah, it doesn't need any uh, special or high kism
no, no.
like NSAID. Yeah.
Yes, so they can use like over the counter medicines while they are seeing you. But we just have to make sure my aim is being a physiotherapist that this pain should be manageable without taking medicine. But because you are too irritated and because you have a lot of other compromise, let's just give some sort of comfort to the body while treating.
And the thing is, like, when you control the pain, it helps in rehab as well. Because if there is pain, there is, I don't know if you know about pain inhibition mechanism.
Yeah,
Yeah, so pain inhibition will be there. So once you start controlling the pain, the engagement in exercises of muscles is improved.
100%. So we talked about hypermobility. If it is hypomobile, there are like manual approach is important as well. So manual mobilization like anterior and posterior rotation technique for SIJ, which is on inside lying.
Is it nutation and counter nutation?
Yes,
Is that
yes,
one? Okay.
yes, you are very right. So it's more like nutation and counter nutation. You can add mobilization. Even I was watching a video on it, he was an international instructor, but I just need to check the reference before quoting it. They were adding muscle energy technique on SIJ, which was quite inspiring for me.
Oh, muscle. I love muscle energy techniques.
Yes, and
They
it works.
work every.
It works very well. I just need to check the photo because I don't have photo, and unfortunately, I do not have any model to just show how we can apply muscle energy technique. But I will be surely sending a photo that how it works and what physiotherapist has to do.
Please do, yeah. And you can all put this all useful links when you like upload this as well. So
Yes.
if yeah, yeah, do put all these pictures and important stuff obviously as a reference.
Okay.
So this is for hypermobility, is it? Are we still talking about hypermobility, or is it just general rehab
Hypomobility.
hypermobility?
If it is hypomobile, it needs mobility. For mobility, we have to go for mobilization.
Yeah, yeah, yeah. Hypermobile, yeah.
Yes. And other than that, as
Sorry, I'm just reading because I think I've mixed them up. I'm making notes. So in hypermobility, it was a stability belt, pelvic strengthening exercises, and stability exercises, isn't it?
Yes. So all
Yeah.
these type of exercises, they will be working for your hypomobility as well in later stages.
Yeah. But you can combine it with obviously with passive glides as well to
Yeah,
sort of
exactly.
create this.
Building up enough strength in your glute muscles,
Yeah.
releasing stress from the hip flexor muscles, working on the paraspinals, erector spinae muscles to just unload them from excessive tension. So all type of muscle system, which was like muscular element, which was there when we discussed about from where this pain can come from.
So when you talk about the muscle energy technique, so which kind of muscles they were involving specifically
S-
for
uh,
SIJ?
I believe it should be your glutes activation.
Yeah.
I will be putting reference by adding here. I will surely do that. So because while generally talking, you are not understanding what I'm saying. I can sketch a photo, but I just need to do that. I will
Yeah.
surely do that. Yes. So muscle energy technique definitely activating the muscles which are overly active before.
Yeah.
And yeah, pelvic floor and stabilization things very very important. I'm just checking in my notes if I'm missing anything in treatment. Mm, and yes, chiropractor adjustment, like they are saying it works, SIJ manipulation. But we can't go for SIJ manipulation till the time of if somebody is really sore and having bad muscle spasm.
Yeah.
And I'm just showing you a key chart which was giving us an understanding of this chart is really really important. Sacroiliac joint dysfunction algorithm for
Very important.
for interventionalist.
Mm.
Can you see my screen?
Yeah, yeah, yeah,
Okay.
definitely.
So because we know about how to diagnose SIJ, so the first step is diagnosis of SI joint pain as per history, examination, and imaging. If yes, if you are sure this is SIJ, while you are treating this patient as a physiotherapist, you can refer them towards specialist for diagnostic SIJ injection. So they have to insert a cortisone injection directly into the SIJ. If this injection relieves the pain, that means it's a diagnostic tool that we are sure that this pain was from SIJ. Okay.
Yep.
So diagnostic SIJ injections less than 50 to 70% pain relief. If patient is saying okay some sort of pain relief, evaluate for other sources of the lower back pain. If there
Can
is
I ask?
a
Sorry, Binish.
yes,
Uh, I'll be quick. Using is it a steroid injection?
yes,
I'm just thinking like because there are lots of risks with steroid injections. So using them for sore diagnostic purposes, which will obviously treat them as well. What is the like evidence to support it that it's actually going to work? Because sometimes they don't work. They can increase the symptoms and the
um,
pressure they pose to the ligaments because they're steroids, so they definitely absorb your tendons and your bones. So I'm just thinking of using it for a sole purpose of just diagnosis. How ethically it's allowed. I'm not like
okay.
how
So
do I
it's
use.
your question is very right, but we are not bluntly going straight away sending patient to specialist for okay go for diagnostic injection. I
Yeah,
being physio, I'm sure 100% that I have examined this patient considering subjective, objective, and special tests. And
yeah.
this patient is fulfilling all the criteria for SIJ. If you have relevant radiologic findings that are helping you or supporting you for your diagnosis, you have another chance of, okay, this is supporting my diagnosis as well. Then,
Mhm.
then this is the third thing. Like it's not something straight away going for injection to identify whether this is the thing or not.
But won't you try rehab first? Because as long as as much as I know, we always try to avoid injections.
Yes,
Try to rehab with exercises first. If that doesn't work, then yeah, you can go for injection.
you you
Combine
you are right.
exercises.
That's what how we practice as well. This was just a recent article of 2021 or
Okay.
2022. Like they were saying that all type of clinicians should have basic understanding of how and when to apply what type of technique or intervention.
Okay.
Otherwise we do the same. We always start with all type of like um, um, options having less possible risks. If
Yeah.
something is
Yeah.
not working, then we look for some other options.
Exactly.
Yes.
Okay.
So I have to share the screen again. So this key is saying if patient is saying greater than 50 to 70% of pain relief, then 4 weeks course of physiotherapy and NSAIDs they can start, or otherwise because they are under the supervision of you and under the supervision of their specialist as well, so they could be advised for NSAIDs. If pain continues with the rehab plan and the medications prescribed by their doctor, continued pain, if yes, then we will be going to refer them for therapeutic SIJ injection. If pain is not if pain is settling down, continue with the conservative measure. After therapeutic SIJ injection, greater than 50 to 70% pain relief for greater than 3 months, then you can go for another dose, because recommended time is one cortisone injection always should be monitored for almost 3 months before deciding for another dose. And another dose means if my patient is, if being a specialist, if my patient is getting improvement with whatever I injected before, then I should think for another dose if it is needed. Otherwise, if it is not getting better, like greater than 50 to 70% pain relief for less than 3 months, then operative candidate. You must go for some surgical procedures. Operative candidate, yes, minimally invasive SIJ fusion, otherwise SI joint, which is, I think, uh, what was that? Fluoroscopic something.
Must be some arthroscopy.
Yes.
Arth RFA, maybe some arthroscopy. Let me check it. Yeah, it's sorry, it's radio frequency
Radio
ablation. So it's
frequency.
using, I think, yeah,
Oh,
it's
yes.
radiation. Yeah,
So it's radio frequency
ablation. So I think you're
ablation.
using the,
So
I think
more
it's like
like,
talk
yes,
something like
it's
radio.
more like um neuromodulation.
Yeah, using radio therapy more like RFA.
So this is not something which like one always has to follow, but this is just a randomized guidance.
Yeah, yeah, yeah.
And every clinician, based on their years and time of experience or their time with the patient, they always can do flexible things, like they can start with. And sometimes I just give trial based treatment to my patient to see if we are getting better, and see, I'm just adding observation based treatment. If your body is
Mm.
saying something positive on whatever I did, that means it's a green signal of we should continue with that. Otherwise I have to reassess you more, or I have to look for some other options other than me as well. And it's never like you are always right, or it's never like you are just wrong.
Yeah, yeah.
So that was from me, just a discussion on SIJ. I tried my best to just make it as
Amazing.
simple.
Very, very nice. Look at my notes. I've literally jotted down everything you've said.
Thank you.
Very useful, very useful. Because I had a patient who had a very very complex presentation, but at the end, it turns out to be it's more Sij dysfunction. So I'm treating that patient for Sij now. So I thought it will be really really useful to have an insight into Sij, just to sort of brush up the knowledge. So it was really really useful, amazing, especially that those points where you're like, where you're differentially diagnosing. So when you were telling me, I was actually sort of envisioning that in my mind. Okay, you know how this is how you rule out your proximal hams. This is how you rule out if there's a nerve involved. Because there was a question in my head, what about the obturator nerve? Because your obturator nerve goes from that, it forms that I think it's a canal or something where your obturator nerve passes out. So this was a really really important point. So that's a feedback from my like, I really love the differential diagnosis part, and amazing presentation by yourself.
Thank
Hats
you.
off.
And I will take feedback from Uswa as well, but I just want to add one more thing.
Yeah,
Sometimes,
yeah,
because of the irritability coming from the pain intensity, your
yeah,
patient gait style is different, or in some time more like, um so if I'm really sore, I could be I could be just walking like that. And if
yeah,
I'm more in, if I am more in this posture, my hip
yeah,
flexors are really, really tight. And
right,
just because of excessive tension in the muscle, there could be some sort of compression on the nerve, and your patient can present with like numbness in the front thigh. And that could
yeah,
be just a secondary thing. If I start correcting the main pain generators and
yeah,
working on their postural things, all these things should be settled down. Or it could be just a primary thing. Both could be the possibilities.
yeah, yeah.
So I always just take it as a holistic thing, how my patient is presenting.
That's the thing. It's a very very important point, because the minute you are building a pattern, you're like, okay, okay, it looks like Sij, and then they start giving you, I feel a bit numbness, and you're like confused. Okay, so there are nerve symptoms, and then you're like, is that a radicular pain? Is that a joint pain, or is it something two different things? So it's a very important point to sort of ponder today as well, that you have put on that. Okay, I will keep that in my assessment next time. That's my uh, that's my take on message for today as well,
Yeah,
like a take.
and sometime I just, with lower back pain, with hip pains, with SIJ, just start releasing their hip flexors, and next time ask
Yeah,
them, how, okay, I feel better. How about your numbness on your front thigh? No, I feel like it's all gone.
yeah, exactly, exactly.
So
Brilliant.
yeah, this is very important. But thank you, Foster. But yeah, it's always like a discussion, and I even have learned a lot, so many things, from you all.
It was very useful. As I said, my knowledge, I think I'm quite weak in Sij, like, because it's not very common. It's very rare Sij pains. So far I've only seen patients. I've been working for like 4 years in NHS up almost now, and I've only seen two patients with like true Sij
Hmm.
uh, presentation.
Great.
Yeah.
Thank
Uh,
you.
uh,
And
just last question, sorry.
yeah.
What is the target population? Is it like more common in females, age group? Do you have any idea about that? I can Google it. We can
Hmm.
just,
Good question. But I believe it should be more common in females as compared to
yeah,
males,
I've seen,
considering all type of causative factors.
yeah, so it's in young people, yeah, because I've seen young, mine were only like 20 to 25.
Exactly.
So common ages are 17 to 25, and then ages between 40 to 60.
Hmm.
Yeah. Because obviously pregnancy puts a load on it as well, so it could be triggered from pregnancy. So those young ages, more common in women as always, like every diseases, but men can also experience it. The two main peak age ranges are 17 to 25, and then 40 to 60.
Yes. Because in the age of 40 to 60, and because of the menopause, because of the hormonal fluctuations, and because of the childbirth things, you're already weak enough and you can just develop it as a secondary compromise.
And it could be degenerative, like 40 plus, your most things degenerate. However, in young, it could be more inflammatory, it
Yes,
could be more pregnancy related, it could be more trauma related.
exactly.
That's like the more.
Yes. Can we hear Uswa as well? And then I will stop recording.
Yes, it was very comprehensive. And the like say कूजे में सब कुछ बंद कर दिया है. So it's like a very 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 good presentation, and we have really learned a lot. So keep it up.
Thank you. But I have learned a lot from you all as well. I tried my best. उसवा वाली बात है, कूजे में बंद कर दिया इतनी जल्दी क्योंकि ये सम अप होने वाला टॉपिक नहीं था.
Yes, it's the skills you have used to cover this up very 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 well. Yeah. So it's called a professional development course actually.
Thank you.
Very.
Thank you.
And you have like sort of given evidences with it as well. You have used papers, references, which tells that you are actually working on your CPD. You're actually building your knowledge according to the like latest information that's available out there. So
Because
that's a
because when we just search for, on Google Scholar SIJ, it just comes up with so many things, and it's the actual art is just to sum it up and put it into one thing, and
true.
so that we can just open one thing. Even maybe when I will be assessing my patient next time, I can just play this video again.
Yeah, yeah. True, 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 true.
Yes.
So
Thank
guys, the
you.
topic will be, I think, shoulder instability. We are